Gynecology and Reproductive Medicine, Division of Surgery at the University of Texas MD Anderson Cancer Center in Houston, Texas. In this segment, I'll be talking about individualizing endometrial cancer care with current and emerging practice-changing clinical data. So let's begin with a quick question. Which of the following treatment options is indicated for patients with recurrent, non-MSI high, or in continuing on our discussion of the receipt of guideline-based treatment in underrepresented minorities, and specifically Black women as compared with white women, we can see that some of these disparities really do reach not only screening, as we've discussed before, but also treatment, where we can see that Black women were less likely to be offered adjuvant radiotherapy and appropriate regimens for their disease. And this did yield worse overall short-term and long-term outcomes, including 30-day readmission, 90-day mortality, and 5-year mortality. Certainly, analyses have indicated that optimal adherence to this guideline-based care can improve outcomes, but does not seem to eliminate racial disparities that are common in endometrial cancer. So let's talk a little bit about the guidelines and recommendations for management of newly diagnosed endometrial cancer. In general, surgery is the primary treatment for endometrial cancer. Now, I will say this is going to include both a hysterectomy, potentially bilateral salpingo oophorectomy, and the consideration of either a sentinel lymph node mapping versus a lymph node dissection. Now, if we tease out early stage, so apparent stage 1, again, the bottom line is surgery is the standard of care. You might consider the use of radiotherapy based on uterine factors or other risk factors. For those patients that may not be ideal for surgery, whether that's because they would like to retain their fertility or if they are frail and have comorbidities, you can consider fertility-sparing options such as hormonal therapy. For women with a more aggressive types of endometrial cancer, but still early stage, that have multiple comorbidities for whom surgery is not an option, radiotherapy can also be utilized. For stage 2, again, we're looking at surgery as well as consideration for radiotherapy, whether that's external beam, IMRT, or vaginal brachytherapy. Once the patient has reached stage 3, which is cancer spread into either the adnexal tissues or all the way into the lymph nodes, again, surgery, if it's possible, is ideal. And the use of platinum-based chemotherapy with or without radiotherapy is acceptable. And then finally, those patients with stage 4 disease, if you can perform surgery and achieve an optimal tumor reduction, that's ideal. Those patients that cannot have a hysterectomy may be considered for radiotherapy. You can consider for endometrioid type tumors hormonal options, including progestins, tamoxifen or aromatase inhibitors. Chemotherapy combinations are often considered the standard of care for this population, but we are seeing more use of targeted therapies, including bevacizumab, mTOR inhibitors such as temsirolimus for endometrioid type, and the combination of everolimus and letrozole for endometrioid type tumors. And then finally, we're going to discuss a little bit during this lecture the use of immunotherapies for this patient population. Now, looking at the treatment of relapsed refractory endometrial cancer, it's quite similar to what we just reviewed for stage 4. If we see a local recurrence, certainly surgery can be considered. And in patients that haven't had radiotherapy, radiotherapy can be curative for local recurrence. However, for those patients that have already had radiotherapy, even in a local recurrence, you're going to be looking more at the systemic therapies that we just discussed. And similar to upfront disease, hormonal therapies can include progestogens, aromatase inhibitors, and estrogen modulators, as well as paclitaxel and carboplatin chemotherapy, single-agent doxorubicin or paclitaxel, and then anti-PD-1 monoclonal antibodies such as pembrolizumab or dostarlimab in MSI-high mismatch repair deficient tumors, or the combination of lenvatinib and pembrolizumab for those patients with MSI stable or mismatch repair proficient tumors. Let's talk a little bit about the chemotherapy standard of care for patients with either an advanced stage or recurrent endometrial cancer. And the bottom line is, based on the GOG 209 study, the combination of paclitaxel and carboplatin was found to be the standard of care. And this was based on a non-inferiority trial where that combination was found to be non-inferior to the TAP regimen, which was paclitaxel, adriamycin, and cisplatin. Now, recently, there was a very elegant randomized phase 2 study that looked at patients with uterine serous tumors and determined that the addition of trastuzumab was appropriate for those patients that had HER2 positive disease, either by IHC or FISH analysis. And that did yield an improvement in progression free and overall survival. Now, for those patients with endometrioid type, the GOG 3007 study looked at the combination of an mTOR inhibitor, everolimus, with an aromatase inhibitor, letrozole, and compared that to another standard of care in endometrioid type endometrial cancer, which was the combination of tamoxifen and medroxyprogesterone acetate. Patients were randomized between the two arms and followed until progressive disease or unacceptable toxicity. And the primary endpoint was objective response, although they did also look at progression-free survival and overall survival. And what we found was that the progression-free survival and overall survival appeared improved in the patient population that was treated with everolimus and letrozole as compared to the alternating hormonal regimen. Now, if you look at the table on the right, you can see that the objective response rate in the intention to treat population wasn't actually much better in the combination of everolimus and letrozole as compared to tamoxifen and medroxyprogesterone acetate. However, the progression-free survival really was where we saw that improvement. Now, that may be driven to some degree by those patients that had no prior chemotherapy, where we saw an improved response rate, but we're waiting on final data to really determine that. The bottom line is the combination of everolimus and letrozole is an appropriate choice for patients with endometrioid type disease. Now, turning to the data for immunotherapy in endometrial cancer, this was the phase 2 Keynote 158 study, which looked at pembrolizumab in patients with microsatellite instability high advanced endometrial cancer. You can see this was an open label phase 2 study where we saw a response rate of 57% in that cohort of 49 patients with microsatellite instability high endometrial cancer. And the duration of response, at least as of the last presentation, had not yet been reached. So when we see that benefit, it is a durable benefit. And we saw progression-free survival in this group of 25.7 months, which is really unheard of. Most of the time when we're looking at progression-free survival in this patient population, we're talking 3-4 months. And so this was really impactful. And that did lead to an FDA approval in May 2017, which was actually based on biomarker, regardless of tumor type. But our patients with endometrial cancer can receive this option. Now, pembrolizumab is also being added to chemotherapy with paclitaxel and carboplatin in the ongoing NRG GY018 trial, which is in recurrent or advanced primary endometrial cancer. So similarly, the agent dostarlimab has also received an FDA approval for mismatch repair deficient endometrial cancer. And this was based on the phase 1 Garnet study, where similar to what we saw with pembrolizumab, the objective response rate was quite high, 44.7%. And this was in a large study of 103 women with endometrial cancer. In addition to this objective response, we also saw a disease control rate of 57.3%. So again, including patients that had prolonged stable disease. And look at that median duration of response was 34.7 months. So when you get benefit from this agent, it really does seem to be durable. And these results did lead to an FDA approval in April 2021 of dostarlimab for mismatch repair deficient endometrial cancer. Now, importantly, dostarlimab is also undergoing evaluation in combination with paclitaxel and carboplatin in patients with recurrent or advanced primary endometrial cancer. Now, when we're talking about novel agents and especially immunotherapies, it's really important to discuss the safety. And you can see here that in general, rates of grade 3 or 4 adverse events were quite low. We saw some fatigue, pruritus, and diarrhea. Really, all comers of any immune related adverse events, we saw some hypo and hyperthyroidism, and then low levels of pneumonitis and colitis. So these are things that need to be identified, they need to be screened for. But in general, you can tell your patients that the risk is quite low as compared to the potential benefit. What about patients that don't have microsatellite instability high disease? This was the phase 1b/2 Keynote 146 trial, which combined the PD-1 inhibitor pembrolizumab with a dirty tyrosine kinase inhibitor. It hits multiple targets, including VEGF, named lenvatinib. And this was in patients with recurrent endometrial cancer. It was stratified based on their molecular features, including patients that had microsatellite instability high disease, which you can see was low, only 11 patients, compared to patients with non-microsatellite instability high or microsatellite stable disease, which is 94 patients. And they were treated with lenvatinib at 20 milligrams daily, as well as pembrolizumab at 200 milligrams IV every 3 weeks. Only about 49% of patients were PD-L1 positive, and 37% of patients had received 2 prior lines of therapy. Now, their primary endpoint was objective response rate at week 24. And please do note that responses were confirmed with a secondary assessment more than 4 weeks later. And based on the results that I'm going to show you, this combination did receive FDA accelerated approval September of 2019 for patients with endometrial cancer that did not have microsatellite instability high or mismatch repair deficient disease. So this is what the approval was based on. These are the responses seen. On the left, you'll see the responses based on the molecular aberrations present. So there was a 36% response rate in patients with microsatellite stable disease, as compared to a 63% response rate in those mismatch repair deficient tumors. And then if you look across histologies, there really was a consistent benefit, whether the patients had an endometrioid type, a clear cell type, or a uterine serous type. So really exciting to see some of the more rare histologies still getting benefit from this combination strategy. Of note, when we looked at the results of Keynote 146 by PDL1 status, again, the tumor shrinkage and the benefit in this waterfall plot really was irrespective of if the tumor was PDL1 positive or negative. So really feeling comfortable that in patients with microsatellite stable disease and PDL1 negative disease, you can still get benefit from this combination. We need to talk about safety, though, because with the addition of a new agent, you do see an increase in overall toxicity. 97% of patients that were on this treatment did have a treatment-related adverse event. Now, importantly, though, among those patients, only 18% had to have study drug discontinuation due to those adverse events. So obviously, we would like to have no discontinuations, but the fact is that the majority of these adverse events can be managed with dose interruptions or dose reductions and appropriate aggressive management. The most common grade 3 or above adverse events were either hypertension, fatigue, or diarrhea. And then they did drill down on specifically immune-related adverse events. That happened in about 57% of patients, and the most common was hypothyroidism. Of note, the most common immune-related adverse event that was more than grade 3 were severe skin reactions. After that initial trial, they moved on with a confirmatory trial, which was Keynote 775, which was a randomized open-label phase 2 study comparing lenvatinib and pembrolizumab at the doses I noted previously to standard of care physician's choice chemotherapy, which included either doxorubicin every 3 weeks or weekly paclitaxel on a 3-week on, 1 week off schedule. Primary endpoints for this study were progression-free survival by blinded independent central review, as well as overall survival. And they also looked importantly at things like response and health-related quality of life. Based on the results that I'm about to show you, we did note an FDA priority review that did yield a full approval for this combination of agents in this population. And here are those results that led to that final approval. You can see on the left are the group of patients that had mismatch repair proficient, or the lack of microsatellite instability high disease. And the combination of lenvatinib and pembrolizumab yielded a reduction in the overall risk of progression of 40%. As well as an improvement in the probability of overall survival, which does appear durable. When they included some of the population that had microsatellite instability high disease, you can see that benefit was retained, again, with improvement in progression-free as well as overall survival. Looking at the treatment-related adverse events, very similar to what we saw in the original Keynote study, where the combination of lenvatinib and pembrolizumab was more likely to see hypertension, hypothyroidism, as well as diarrhea, although the rates of diarrhea were still quite high in standard of care chemotherapy arm as well. We saw similar levels of things like nausea and vomiting, as well as similar levels of fatigue. Do note that, again, with the grade 3 or above adverse events, hypertension was the most common. We know there can be adverse events with immunotherapy, whether alone or in combination with lenvatinib. So it's really essential to ensure that your patient can remain compliant with this life-saving therapy. So what we like to do is really when you're starting these agents, educate the patients in depth about the toxicities that they might have, and make sure they understand to contact you immediately if they occur. I even like to check in with them every few weeks to make sure that they're doing well. In addition, if there are other healthcare providers that are involved in their care, make sure they know that they're receiving immunotherapy, and that way they can address issues as needed. You want to assess for these immune-related adverse events at the minimum of each cycle for the first 3 months, and that includes laboratory tests such as thyroid tests, where we really like to check them every 3 months for the first cycle, and then every 2 to 3 cycles. And maintain a low threshold for steroids or immunosuppression if you're concerned based on these immune-related adverse events. We've provided a table here to help guide you. So in general, if you're looking at a mild adverse event, grade 1, you want to symptomatically manage that patient. You can continue their immunotherapy, and really in general, immunosuppression is not going to be needed for that group. Now, if you're moving into a mild to moderate or grade 2 adverse event, again, symptomatic management is key. You want to consider discontinuing until resolution to grade 1. And if they're really having intolerable or persistent symptoms, you want to consider immunosuppression or steroid therapy, and involve those consultants as needed. We'll often get our consultants involved very early. If you've got a rash, get dermatology involved. If you're dealing with potential pneumonitis, get Pullman involved as soon as possible. Now, once you get into severe adverse events, grade 3 or 4, you have to discontinue that therapy. You may consider starting it again, but that really is dependent on the resolution of symptoms and their ability to come off of immune suppression. And again, for these grade 3 and 4 adverse events, you really need to involve your consultants early and often to make sure that you get the best outcomes. Which of the following treatment options is indicated for patients with recurrent, non-MSI high, or mismatch repair proficient endometrial cancer? Number 1, dostarlimab. Number 2, lenvatinib plus pembrolizumab. Number 3, pembrolizumab. Number 4, platinum-based chemotherapy plus bevacizumab. Number 5, tamoxifen plus megestrol acetate. And number 6, uncertain.